Chapter 3 is going to cover physical well-being, physiological changes in health in older age. And again, as I always say, make sure you read the full text in the textbook to get all of the information about this chapter. The learning objectives of this chapter include explaining the 4 biological theories of aging, identifying normal physiological changes that occur with aging, defining good health, disability, and other terms, identifying the most common chronic diseases, analyzing accidents in older adults, comparing the usage of physician services and talking about geriatricians, and identifying some health promotion programs and strategies for older adults. So what's important to understand are these biological theories of aging. How do we talk about aging from a more scientific biological standpoint? So biological aging, or senescence, is the normal process of alterations over time in the body and its organic systems that eventually affect our functioning, but do not necessarily result in disease or death. Yet, we often link aging with disease because declines in organ capacity and our immune system make us more vulnerable to illnesses that increase in incidence with age. In other words, aging is a gradual accumulation of irreversible functional losses to which the average person adapts. It's a lot of information, but essentially, researchers are trying to understand this process of aging through various theories about why we age and what that means. And so we're going to talk about the 4 main theories of aging, including wear and tear theory, cellular aging theory, immunological theory, and free radical theory. So first we have wear and tear. This theory purports that the organism simply wears out over time, and that this process is influenced by environmental stress, such as poverty and poor nutrition. Essentially, our human cells wear out, and the existing cells cannot repair the damaged components. So the title kind of sums it up. It's over time you have wear and tear, almost like you think of a car vehicle. The second theory is called cellular aging, and this one purports that aging occurs as cells slow in their number of replications. So as we know, cells replicate, and this is saying that over time we see less and less replications. So they believe that aging has a biological clock that determines lifespan and bodily deterioration. Essentially, cells stop replicating after a certain number of times. The next theory, immunological, is they purport that aging is a function of the body's immune system becoming defective. They say that the immune system becomes less efficient and therefore allows for various diseases that we see that are part of aging. And finally, the free radical theory is that the progressive, irreversible accumulation of oxidative damage to cells explains our loss of functions as we age. And essentially, this occurs when an organism cannot detoxify or repair damage, allowing for diseases to occur. So I recommend spending some time reading about these specific theories in more depth in the textbook to kind of get an understanding of the difference between them. I can guarantee that there are some questions on the test about these theories because I think it's important to understand kind of what we think about why aging happens and some of the foundational differences in what could be happening. Okay, so, once we kind of have some theories about our aging, let's actually look at the realities of aging. On a day-to-day basis, what does aging look like in older adults? Well, there are some general tendencies or patterns to aging observed in the majority of older adults. However, this does not mean everybody will age the exact same. You might know some older adults in your life that are close to the same age and have very different lifestyles, chronic conditions, activity levels, etc. So we're just going to kind of talk about what are these general tendencies or patterns in aging, but again, this does not mean that everybody experiences these the same way. So some of the main appearances that will change is that you'll often see older adults losing some body mass, losing weight, and also reducing in their muscle tissue, losing some muscle over time, muscle tone and tissue. Vigorous exercise can help reduce the rate at which older adults lose weight and muscle tissue, so continuing to be active can help with that. We also see some more appearance changes, such as gray hair or wrinkles and spots. The wrinkles and spots occur because of a decrease in elasticity in the skin, so the wrinkles can form, and then an increase in hormones that increases darker pigmentation, which allows for spots to form. And then we see issues with temperature control, so inability to regulate maybe temperature as easily as one could before. We also see changes in lung capacity. You might notice reduced height, and this is just as bones begin to kind of compress together and the space between bones reduces. It can kind of reduce the stature. Balance and movement, because of changes in the way the body is moving, there can be issues with keeping balance, and we'll talk about falls later and the importance of balance and mobility for reducing falls. And then we can see changes in blood pressure due to aging. A bunch more. Changes in hormones. You've heard of, menopause in women. So there are, over the life course, hormone levels change for men and women in a variety of ways. Bladder function, which can lead to incontinence just due to decrease in ability to tighten the muscle enough. Reduced appetite. We do see a reduction in brain mass, which is not necessarily the same as reduction in cognitive abilities, but we'll talk about that at some point in the semester with thinking about Alzheimer's and dementia and cognitive impairments. And then we do see disruptions in sleep, mostly connected to this change in hormones. One more, we see changes in ability to taste and smell as strongly as before. Often there are issues with vision, lots of different things within the vision category that can happen as we age. Reduction in hearing, touch deterioration, just really a little bit of a loss with all of the senses. And I recommend that you spend some time reading all about these in the textbook. They have specific examples of all of these there. So it's important to really define health and functional ability as we talk about aging to have a better understanding of what does it mean to be in good health when you age. Well, the World Health Organization defines good health as a state of physical, mental, and social well-being. So you'll note there that it's not just the more physical things that I talked about in the past few slides, but it includes mental and social well-being as well. And this kind of three-pronged approach is commonly used in gerontology to really focus on the fact that your physical health isn't everything, but mental and social health matter as well. And it may be hard for some people to believe that most older adults do not actually perceive themselves to be in bad health. They understand that some of these changes are a natural part of aging, and so they don't necessarily see themselves in bad health overall. So let's just talk about a few terms. Health status is the presence or absence of disease and the degree and the level of functioning. So what is a person's health status? Functional ability is what someone can do or think they can do and how healthy they are. So sometimes the perception is important because it might matter more what they think they can do versus what they can actually do. The instrumental activities of daily living or activities of daily living is a measure of functional ability based on the point of level of care that someone might need. And we have some examples of what that looks like on the next slide. In disability, these are impairments in the ability to complete daily tasks that may mean assistance is required. So some ADLs include personal hygiene, continence, dressing, feeding, moving around, and using the restroom. Now, these are basic self-care tasks. And on the right side, we see instrumental ADLs. And these are just some other, a different category, including companionship, transportation and shopping, preparing meals, managing the household, managing medications and finances, communicating with others. What we see is that around 40% of older adults living in the community need help with one of these tasks. Only a small proportion actually need help with 5 or more of these tasks. And when you're starting to get to where you'll need help with 5 or more, this is when often hired caregiving support, either in your home or moving into a nursing home, something where you can get that 24/7 support needed, is considered. It's when someone gets to that point. Okay, so some common chronic diseases. Again, your textbook goes through a bunch of examples of the top common chronic diseases. I'm not going to test you on, what are the rates of cancer or anything like that in an older adult population. So just check your textbook for some specific examples. I'm going to talk more in an overview way about chronic illness in older adults. So 80% of older adults have one or more chronic illnesses. And the term comorbidity means having more than one chronic illness. So you can see in the chart below, one or more chronic condition is the purple bar, and 2 or more chronic conditions or comorbidity is the orange bar. And we can see when we start moving up the age ranks into older adulthood, we see more and more older adults living with at least one chronic condition. So you can see how important it is to consider chronic illnesses in older adults. Ten of the most common chronic conditions for adults 65 plus include hypertension, which is high blood pressure, high cholesterol, arthritis, coronary heart disease, diabetes, kidney disease, heart failure, depression, Alzheimer's, and COPD. And again, I encourage you to look in your textbook to get some more descriptive information about these top chronic conditions. So why is it important to think about this, and why are these rates of chronic diseases increasing? Well, our life expectancy is increasing. So we have improved our sanitary conditions and we're living longer. And so therefore we're actually having time to develop these chronic conditions. Whereas in the past we might have died from tuberculosis or some other infectious disease. Now we're living long enough to actually be able to have these chronic illnesses. We're also seeing higher rates of unhealthy behaviors, including smoking and dietary risks that lead to obesity. And actually, treatment advances are actually leading to higher rates of chronic illness because medication for things like hypertension and cholesterol allow individuals with risk factors for heart disease and stroke to live longer lives with chronic illness rather than dying from the disease earlier. And just increased public awareness for conditions means that more people are requesting diagnosis and treatment rather than going undetected. So those are kind of the top reasons why we're seeing more and more chronic illness in our country. And you can see here in the chart we have chronic illnesses like diabetes, asthma, COPD, cancer, cardiovascular disease. Those are increasing over the years, 1990 to 2020. You see that that's going up, whereas kind of communicable diseases and injuries are reducing. So we're seeing less of death from those types of things, but more chronic illness. However, we do see health disparities in chronic illnesses. So women experience more functional illness, which limits their quality of life. And therefore, we see more women with higher rates of disability, whereas men are more likely to die from a chronic disease. So women are getting diseases but living with them longer, whereas when men are diagnosed, they're dying from the diseases or having different diseases and they die sooner. In terms of race and socioeconomic status, we just see that chronic diseases occur at earlier ages in these groups, mostly related to these health disparities that we talked about in previous chapters. And 2/3 of deaths among older adults are due to heart disease, cancer, stroke, and diabetes. And a lot of these have lifestyle factors related. So it's important to think about the lifestyle factors and health prevention strategies for them. Okay, moving into accidents and falls. The risk of death from physical injuries is 4 times greater for 80-year-olds than 20-year-olds. And this is often more related to falls than anything else. So falls and injuries in older adults often lead to hospitalization for recovery, and then being in the hospital actually increases the risk of other issues such as infections, pneumonia, other illnesses, just being in the environment of a hospital. You'll see in this graphic, 1 in 4 older adults report a fall. More than 7 million of those falls require medical treatment, and more than 27,000 of older adults died as a result of falls. So falls are very dangerous in older adults. Again, falls are a leading cause of injury-related deaths, and we're actually seeing an increasing rate of falls since 1990. So this is not something we're getting better at, but something we're actually getting worse. Particularly when falls lead to a hip fracture, 20% of those patients die within a year. So it's very dangerous when a fall leads to a hip fracture. Women are more likely to fall than men, and it really becomes a cycle for health problems because older adults become more fearful about falls and therefore less active, and then that can lead to a host of other problems. We're working to prevent falls, thinking about creating a safer environment, installing handrails on staircases, picking up trip hazards, adding lighting, decluttering areas, using non-slip things throughout the house. And then also thinking about the things other than just, creating a safe environment at home that we can do for our health to decrease falls. One of these is checking prescription side effects. Many times mixing medications can create vertigo and dizziness that might increase falls. Just getting regular vision checks can help, as older adults may not realize that they're having issues with their vision. Exercising regularly can improve muscle tone and ability to catch oneself. Improving diet and wearing shoes with traction can help as well. Part of what people think about when they think of accidents with older adults is actually driving. But some interesting information about older drivers. 90% of people 65 plus are still driving. And very interestingly, they only cause about 7% of accidents, compared to 43% of accidents caused by under 24-year-olds. Think about that. 7% of accidents are older adults. 43% of accidents are under 24-year-olds. This is because older adults are less likely to be speeding, drinking and driving, taking risk-taking behaviors. However, we do see a high level of death rates when older adults are involved in accidents. And again, this is what we talked about before, because when older adults are injured and hospitalized, there are higher rates of infection and other tertiary issues from that accident. Some of the factors in poor driving that we see for older adults is that they may have poor judgment of distance, or they may drift, they may have a slower response due to some of these physiological issues that we talked about at the beginning of the chapter. But again, this is just generalizing. Not all older adults will have these issues with driving. What many places are doing, many states are doing, is asking older adults to begin taking the driving test again after a certain age, or if a doctor recommends it. I know in California there are driving tests for older adults to just ensure that they're still safe when driving. All right, so thinking about more turning to health promotion. Older adults, age 65 plus, have an average of 7 doctor visits compared to 1 doctor visit for young adults. So they're going to the doctor 7 times more than young adults. And they have, on average, 3 times as many days in the hospital. They can take up to 8 to 9 medications a day on average. And what we can do is really focus on hiring, training more doctors to be geriatricians. That's geriatrics, that comes from the word geriatrics. These are doctors that focus on older adults to better serve them. So geriatricians can better serve this unique population by taking into account specific issues like them taking multiple medications at a time, the issue of comorbidity, the importance of fall prevention for older adults, versus a regular doctor that may have limited knowledge because they have to study the entire lifespan. So one thing we're trying to do is push more and more geriatricians in hospitals to work with older adults. Continuing with health promotion, the idea is these are health education and environmental changes to enhance an individual's ability to improve their well-being, not just manage their diseases. So it's going beyond that physical component to the mental and social component as well. Changes could include diet, exercise, or cultural attitudes about health. Nearly 80% of chronic illnesses may be related to social, environmental, and behavioral factors like poor exercise and nutrition. So thinking about programs that work with older adults, these include increasing physical activity, giving them space and knowledge about how to engage in physical activity. A big one, of course, is fall management, giving them confidence to be active while preventing falls. Talking about nutrition, especially when it's personalized to older adults who may need a different information about their nutritional needs. And then self-management of disease. So learning to be confident and self-sufficient in taking care of their health for specific health issues such as diabetes or high blood pressure. Things we can do to improve the impact of these programs is to take individual factors into account, thinking about neighborhoods that older adults live in, ability to get to places to participate, transportation to participate in these programs, thinking about these individual factors. Providing social support, so building these into their communities rather than asking them to come to you, you go to them. Sponsoring intergenerational activities so that we can pair younger and older together. Designing accessible resources, again, thinking about transportation, thinking about people from all different backgrounds of activity level, or if they're in a wheelchair or a walker or need support. And then making it available and affordable. So again, bringing it to them in their communities, making it something that they can participate in at a low cost to them. In conclusion, make sure you read the summary section of Chapter 3 for full details about what we learned this chapter. But the aging process is gradual, becoming more rapid after the age 70, with the rate of decline varying among organisms. There are 4 theories of aging to explain the aging process. We have wear and tear, cellular, immunological, and free radical, all with very similar but different ideas about what is happening in aging. There are many physiological changes that occur as a normal part of aging for most older adults, but not all across the board. There are individual differences. And chronic diseases are prevalent in older adults, with the leading causes of death being heart disease, cancer, stroke, and accidents such as falls.